Well, thank you for the invitation. I'm really happy to share something that I do. And my lecture is about how do I do decompression with the UV technique. First of all, I don't have any conflict of interest. I want to start with you share something about the philosophy of the UVE, how is it born for the necessity to be more effective in the central decompression, was origin in 2016 in Argentina for the doctor De Anthony. And then this was adopted by South Korea, who developed the technique, and now we know they are the most with more experience with UVE and other endoscopic techniques. And in the beginning was only we can do it decompression and discectomy, but the quick adapt of the technique uh, make to move forward to another indications with the technique like is like now fusion, revision, doing multi-level decompression, or even now tumors, but only for the lumbar. Currently, we know there is an ecosystem of this technique, like another endoscopic. We can do lumbar, cervical, thoracic, not only for the compression or fusion, even reconstruction, tumor, or infection. So the indication now are really wide, not only like before for the compression. And what is different to biportal with another endoscopic technique? Well, we have two portals, and it meets some advantage because when you can see here, you have one portal for vision or endoscope and another one for your instrument or portal to work. So this gives you a unrestricted movement. You can move in any angle, any depth, without the necessity to reposition the portal. And another thing is the continuous fluid, the irrigation is independent to the portal, work portal. So this gives you have always a good visualization, clear visualization, and work with more confidence. So this is some different with, especially with uniportal. We have three principal approaches in lumbar spine. There is paramedian, paraspinal, and inclinatory. For paramedian approach, we use for all central pathology like unilateral decompression, lateral recess, contralateral decompression, lumbar fusion, um, even a revision, infection, etc. And the paraspinal, we treat all the foramen or extraforamen pathology. We can do transisthmus, transalar, lumbar fusion, foraminal, extraforaminal, far lateral pathology. In lateral recess, there is less common because you can use another approach, but it's really used for lateral recess, especially where it's for cyst or bone pathology. But is you need a lot of experience for do this approach. Mm, right. And maybe we know this the indications and contraindications. Now are really a really few contraindications, and this is relative. The major instability and high-grade spondylolisthesis, because some um, endoscopic surgeons can do this with bipolar. Severe deformity, if you need to correct deformity, yes, maybe you use another minimal invasive techniques. But if it's only the compression, you use UVE. And this is the only contraindication, this mechanical axial back pain. And what question you need to do before you perform the surgery? First of all, correct diagnosis with correct patient, with correct technique. This don't change with any technique. But because I say that, because sometimes I saw in beginners, that maybe you can see the MRI, only the imaging studies, and they want to perform a surgery, but sometimes don't match with the symptoms with the patients or with you so in your physical explore. So if don't match the symptoms with the image, you need to study more this patient. Of course, you need, if this patient have or no instability, because if have, you need to be prepared to fusion, not only the compression. And you can do it endoscopically, of course, if you have the experience. And this other thing is very important. When you plan the surgery, you know what is the goal of the surgery. Communicate with your patient before you do the surgery, because now the patients have a lot of unrealistic expectation about the surgery. So you need to put on the table, be very clear what is the goal of the surgery, what can improve and what not. And another thing that I can share with you is the fragile patient, because sometimes we put more value at the age of the patients in when doing endoscopy is not important. The important is the fragile patients. If these patients for the fragility or comorbidities not support or is impossible to do a surgery, well, you can offer another alternatives. But it's for the fragility. We can do in elder patients with problem with is some this is another advantage with endoscopic. And what I do my plan pre-op. First of all, I search what is the pathology. If it's central stenosis, if have lateral stenosis, if have a foraminal component or both central and foraminal, you are prepared before to start. That you need to prepare your patient and all the team. You maybe will be do two different approach. Of course, the facet orientation and hypertrophy is very important because you need to know how much bone work need to do. Ligament flavum is very important because in using this patient, in this, I did a surgery L5, S1, and I can see the flavum ligament is really thin. And like you see here, I always mark my ligament. And when I finish my bone work, don't have flavum ligament. So you uh, immediately see the neural structures, and you this keep on mind before you start the surgery, not during the surgery, to avoid complication, of course. And if you have a contralateral pathology. So my mental map I do is in my CT scan, I mark my bone work. In this case, with a left F5, L5 S1. So I measure the work I have to, and I keep on mind, and I do it during the surgery. Of course, I mark what the neural structures I need to work. In this case, was central and lateral races to be a very good decompression, to be the not only the central roots, the ghost root too. And of course, here I just want to show you the importance on to see your flavum ligament. When you have this on mind, well, the next two goes to perform. First of all, in biportal, something very important is the portal. For the compression, your landmark is the union of the spinous lamina, and you can do it in your AP with fluoroscopy, mark, and then draw a line, your medial line to the pedicles, and mark need to a separation with in portals and to that 5 to or 3 centimeters each other. But something that I want to share with you is the portal no are static. It's really important to the plan of the portals, because the triangulation in UVE is most the 50% the success of the surgery. So you need to really good plan to portal, and is why? Because depend of the target of the pathology, you need to plan your working portal at your own favor, help you for you in the pathology. Because if you only plan with the dot point, initial point, maybe you can be able to attack the pathology or your endpoint of finish surgery. That is really important because I saw in some novice surgeons, endoscopic surgeons, they plan only the beginning, but sometimes can go attack the pathology and another thing. When you finish, maybe you can do a bilateral decompression with recess, and ipsilateral recess is some more difficult if you don't plan correct your portals. So it's really important the create of the portal. And another thing is depend of the patient. I mean, if the patients have overweight, I recommend you go more lateral. Your portal go more lateral, the standard. And this is the oral, not static. You need to play with them and plan before start because sometimes you can follow with the surgery because you are struggle with your own portals, okay? And when you create your correct portals, then it use the triangulation. You make your skin incision and confirm your triangulation in AP and lateral. This is at the beginning because then you only shot in the AP. But at the first cases, I recommend you level confirmation before incision in AP and lateral. Because it's one of the principal complications or struggle you see in the first cases is more common in cervical and thoracic levels than you grown level. But sometimes in the beginning, maybe in lumbar could happen. So it takes a really few seconds to take it. And another very important thing is the irrigation. If you use bump or gravity, is good. Two things is preferent for the surgeon. You need 30 to 40 millimeters of mercury, and you need to be sure, like I say here, the inflow and the outflow are correct before you start the surgery because the irrigation is very important not only for clarify your field because they help you for a small bleeding, a separator. Another very important thing is a thermal buffer. So be sure that this working only before start. If when you are working, you be sure the inflow is okay, but the outflow is more important even. So this is your check before you start. And another thing maybe we don't take the importance is the ergonomy for the surgeon. You need to put your table at the 80, you work with the elbow in 90 degrees and your shoulder are relaxed because the fatigue for the surgeon is almost at the 40 minutes is variable. But as surgeon, if you have a large surgery, multi-level, fusion, etc., if you are with fatigue, you don't think you want to finish the surgery quickly. So maybe you don't have the specific objectives with the surgery just because you are tired. So this is something for you, the work more calm and more easy. When you are start and you create your triangulation, the first of all you want to see is for orientation is see the first landmark. Is this figure is the union with the spino-laminar union. Okay, this is if you don't see it, you can start drilling or doing anything. So first of all, your triangulation, confirm your level, create your space, your window operate space, and then clear your lamina, your lower lamina of the upper level, in this case is left, and see your interlaminar space, and when you see it, you start the drilling. I recommend you always do all bone work first, the flavum don't touch until the end, because protect you for the neural elements don't suffer any injury. So first of all the compression bone, all the work bone, and it's easier to control the bleeding too, because you control the bleeding bone first, and then the plexo or the new vessels bleeding a lot, so you is more easy control your blood. And when you finish your work, your bone work, then you start with remove your flavum. And another very important for try to short the length curve is always follow the same steps. Be reproduce the same sequence for easier, more comfortable or familiar with the endoscopic anatomy and reproduce the same steps. This gives you more confidence and advance or go forward more easier in the next cases. So what I do in the infinite way. That means I do the ipsilateral, then pass contralateral. First of all, the bone work, and then in in 7 steps, and then go for steps, remove the flavum. So I start in my landmark, clean my lamina, then work with drill, complete with Garrison, go to ipsilateral facet joints, then go to the ipsilateral lower lamina, and then pass to medial line, go to contralateral lamina, contralateral facets, and finish in the inferior lamina. When you finish to bone work and retire and remove your flavum, I always check my 9 points. That means the all my work, bone work, the compression are correct, and the lower lamina, ipsilateral facet, ipsilateral lower lamina, medial lamina, and contralateral in the same way. If I see this, I next with the hemostasia and finish. So I try to, in a really short video, I create my space. This is my line mark, the union with the spinous lamina. I clear it. I can see my interlaminar space, and there start with the drilling. Drilling first. I like to do eggshell for safer or easier remove ligament after. I complete my laminotomy with Carrison, and after that I move with the facet joints, ipsilateral fasten joints, first vestibular drill, and then complete with Garrison. I always do the same. And finally with the lower ipsilateral. After this, I clear my medial line, like you can see, and then go to the contralateral laminar, facet joints, and lower lamina. And finally, I remove my flavum and check my decompression is complete. Contralateral, ipsilateral. So this is the way I do my decompression. So what are some endpoints you can see for you be sure are okay your decompression? Well, if you see your root free or pulsating your dural is because you have a complete. In these cases was at this hernia. I only do, I remove the enough flavum. I don't need to remove all flavum ligament to do this. Only necessary to let me go for the herniated disc and see my root are free. In paraspinal, in this case, it was stenosis foraminal. I can see all my root free, and in this space, I can put a dissector and pass freely is enough. You don't need to do more work here. Another thing some surgeons told me is about the over resection of the facets. If you have your pre-op, you can plane on until 50% of the facet, you don't provoke instability. But sometimes I can see is almost all the times we don't do over resections. It's the all contrary. We short with the compression because we do a lot of bone work and think on our mind. I do too much is enough, but not. The truth is not. Sometimes one of the principal complications is the suboptimal decompression, and you need sometimes redo the surgery because was enough decompression. So don't have fear to do a really uh, bone work because sometimes specifically in the facet is something that you can do before you start the surgery are hypertrophic, so the bone work are too much. Sometimes that I do is like you saw before, I measure my facet, my bone work that I do. My drill is 4 millimeters. So I thinking, okay, if my decompression are 6 millimeters, my drill is 2 more millimeters. And I have on my mind how much I work. And for that I saw in the control MRI or CT scan, the work was good and don't have instabilization. So don't have a fear to work enough bone because it's more frequent you do suboptimal decompression, the over resection. Of course, like I said before, instrument is very important to help you. Parallel to the pathology, is more important the dot point to start. And I just this is something that I showed before, the decompression contralateral. If you see all the structure, neural ipsi and contralateral decompression, your work is finished here. Another thing that I use a lot of UBE is when I have to do a revision because the endoscope give you a more visualization, you control more the bleeding, all venous plexus or the new one. And let me, here you have a lot of scar tissue, fibrous tissue, and the anatomy, the challenge you have in these cases is you have altered anatomical landmarks. Sometimes you use only fibrous tissue and you can see it a normal tissue. So you this study before and be prepared when you start. And sometimes you have other adhesions to the dural. You be careful here because in revision cases, it's more frequent the dural tears. Of course, a lot of epidural bleeding, and you don't sometimes don't have phlegm, so you need to be prepared for that. But something I like in do with UBE, you have freely movement. You need to be very patient in this surgery because you need to go very slow to recognize the structures. And sometimes that I do is if the first surgery was in the right side, I go for the left to start in the, for say something more recognizable anatomical and then go to the revision pathology. But this is bilateral. You need to plan your portals to the structures that let you go and go forward to the surgery with the more safe possible. But the irrigation give you some visualization. You can see here the past suture. This patient have an open surgery. You with patient go to retract all the scar, all the tissue, and you start to recognize like here the phlegm. Go to cleaning very with a lot of patients, and like you can see here, I decide to don't remove all the scar because have a dural adhesion. I do a very extensive of decompression in this patient and decide to let here this scar because the dural tear is more I decide is a complication that I have, and with the good decompression this adhesion here don't happen, no is no matters. Okay, so we need to know when stop too. But yes, it's excellent in the revision to me. Now, of course, if it have you change all the instrumentation, well, maybe another thing. But if it's this, endoscopic is a really good technique for that. And how to prepare for avoid some complications or struggle during the surgery. Before you enter, you need to do the portals. Like I said before, something is important too that I don't say before is the separation of the portal because if you do too medial, you struggle with you fight your endoscope with your instruments so you can start your surgery. Don't let and then you need to redo your portals. And this is unnecessary if you plan before you cut your skin. And if it's too far, you can find them and you can fall and you can start your surgery. So need to be in the good distance and the good, very good distance to the pathology, to start point, to pathology you cannot treat, and your end point. Another thing is the irrigation, like I said, not only for visualization, this is very important for thermal and bleeding and separate your structures. Maintain your field operation open. And of course, for you, for help to you, the table aids. And intraoperative, another thing you to do is the orientation. In the first cases, you lose orientation. You stop, don't follow up, stop, take a shot with your fluoroscope. Your fluoroscope is your best friend in the first cases. So reoriented and then continue your surgery. Don't, if you don't know where you are or don't see it, don't follow the surgery because you can have a really severe complications. Of course, the facet over resection, like I said before, you plan before, make your measures, and don't be afraid to do it, the enough bone work. And if you maintain something that can you see, if you see the medial wall of the pedicule, that is enough. It's another landmark they say you do enough facet resection without instability. And this is another thing that sometimes we don't have on mind, thermal damage. And this is because this is important irrigation because the irrigation is a buffer thermal. So if it's inflow and also maintain a good temperature inside. And another thing is the use of the radio frequency. Something that I can told you about is don't use your radio frequency continuous. 1 2 seconds, stop. 1 2 seconds, stop. The drill is the same. The drill, if you are drilling continuously, they have a more temperature. It can then damage the around structures. So the drill is the same. Drill 2 seconds, stop. 2 seconds, stop, and be sure the outflow it's okay. And of course, the dural tears, everybody is exposed to have a dural tears. And the way that I manage is if you have content, dural structures, neural structures, if they're less than 5 millimeters, just observation. If it's between 5 millimeters, 1 centimeter, I put Tacosil or Duragen or even fat of the patients and continue. Or sometimes I do a suture. If it's more than 1 centimeter, I do suture. Of course, if you don't have the experience to do that, convert to open or tubular surgery. But if there are no content neural structures, if you can reduce, you follow the same that I said. But if it's impossible to reduce, you need to convert to tubular or open, depend your experience. And the judgment errors, like I said before, good correct diagnosis with correct patients, with correct technique, that is something the are good results because the endoscopy for itself is no magic. So you need a really good pre-op planning. And of course, don't miss the pain driver because sometimes the patients only have pain axial. The surgery don't resolve it. And for that, it's very important to learn curve. Have 3 phases in UBE. The preclinical, where you have, if you don't go to take a fellowship, you need unless a lot of cadaver chops, courses, lectures, and have unless 10 procedures on cadaver, observe in centers or with expert unless 20 cases, and have 40 hours of endoscopy anatomy to advance to the clinical phase. They are 100% with a tutor with you. And then another for consolidation phase, you start doing for yourself but have something on phone or video call if you have some struggles. But in the first cases, don't try to do all in one case. First of all, observe, see how the expert do, recognize the structures, how they move the instruments, then you do portals. When you domine the portals, advance to then exposure, drilling, laminotomy, then decompression, controller, etc. This is the learn curve. And there are some metrics for measure for yourself. The reduction the time point when you become master reduce 70% the time of surgery. The complications are lower, the conversion rate almost none, but the most important, the patient satisfaction is really good. And what happens when you are mastering bipolar and lumbar bipolar? Then you continue with cervical and thoracic. No step this length curve because in lumbar you have complications, but in cervical and thoracic there are catastrophic complications. So you need be with this length curve. And the paper said they have a really good results even 1 year after the surgery. Really few lose blood loss. The hospital stay is really like 1 day. I don't stay more than 1 day. The patients, even some surgeries, I send their own home the same day. And of course, the complications are really lower. So finally, some message that I want to share with you is um, never operate if you're not sure for indication. Select when your patient specifically in the first cases. Don't try to do a complication cases because you then avoid this technique. So you start with discernation or simple decompression, ipsilateral or unilateral, to trying to do any and be humble to recognize your abilities. Another thing is every case you always be sure they have all the team, all the equipment, and you plan really good your technique before start. And again, bone first, flavum last. This protect your neural elements and plan really good your portal. This is 50% of just your surgery again. If you are loose, take a stop, take a minute to reorientation. This is possible. So never follow your surgery if you had a bleeding or you're not sure where you are. And of course, UV is another technique. The judgment of the surgery is not change with the technique, and the endoscopic no don't means the other technique disappear. It's another technique you can offer to your patients with really good results. So this is my social network, and thank you so much for invitation.
Thank you, Professor Dr. Bueno, for a spectacular presentation. We were breathtaking listening to your presentation before you joined. Before you joined with the Ukrainian neurosurgeon and with Turkish neurosurgeon, we were discussing that the endoscopy is the future of the degenerative spine. So you proved once again the point that it's indeed is the future. And I'm very happy you mentioned about the learning curve. Because most of neurosurgeons we are scared because we feel comfortable working with the microscope. So changing our professional landscape, it's a risky step, but you showed that the risk is worth worth it.
Yes,
And
definitely.
I would like to invite to the stage our Ukrainian colleague, Dr. Sergey. Maybe you would like to comment or contribute.
There is also Zorian here. Also, he's
Yes, and
from
from
Ukraine.
Bulgaria, Dr. Edwin, we
No,
have
no,
as well.
Zorian here.
Sorry,
But,
okay.
he's no name on the. Okay, Sergey, are you here? Okay,
Okay.
but Sergey cannot turn on his camera. Okay. Sergey, you can talk.
Yeah, I can talk. Hello,
Go on.
doctor. How many endoscopy did you perform during the last year?
In my last year, I did like 250 surgeries.
250 surgeries during year.
1 year, yeah.
What endoscopy for herniated disc and spinal stenosis?
In my country, the principal I did in almost endoscopy surgery are decompression surgery are like 70%, another 20% are disc herniation, and another are fusion, deformity, etc.
I'm really interested how many dual tear do you have during the surgery? It's really interesting because how much? Dual
Dural tear?
dual tear during
Yes.
during herniated disc and during spinal stenosis. And always do you remove ligamentum flavum during spinal stenosis or not?
I removed the flavum piece by piece in several stenosis. I don't recommend you do it in one piece or half piece because it's more susceptible to do a dural tear. So when it's several stenosis, I recommend you do it piece by piece to avoid this complication. Yes.
And how many percent do you have during tear during herniated disc?
Herniated disc a year. I perform like, I mean, for this total of cases are like 20 or 30% of my patients. In my country, is more frequent the stenosis than herniated disc.
He's asking how many dural
Here,
tear percentage of,
in the hernia disc, I don't have any until now. I have dural tears in several decompression, but in the disc herniation, none.
In severe decompression. Thank you very much.
Yes.
Good
Thank you.
experience and good presentation. Thank you very much.
Thank you so much.
And we have some comments in the chat part. We have Dr. Harshad Parekh. Hello and regards from Mumbai, India. We have Dr. Edwin Vasvi from Varna, Bulgaria. Thank you for your excellent presentation. I see you are a very experienced endoscopic surgeon. It was a privilege to listen to you.
Thank you so much.
And we have Dr. Sadef, Dr. Mustafa Sadef. Thank you for your presentation. What are your experience or key technical tips regarding the UBE technique in revision cases, especially for patients with a history of prior implant infection? Does UBE offer a significant advantage in minimizing the risk of recurrent infection?
Yes. Some tips can I give you to start point is if you, like I said, if this patient have unilateral work, go contralateral, but it's bilateral, you plan MRI.
He didn't specify. Maybe Dr. Mustafa, could you specify?
Mustafa?
Or is it specific in infection? In
Infection case,
yes,
infection
in
case, yes.
infection, in my solution, I always put antibiotic. For irrigation, have antibiotic, you can do that, but it's really good. It's really good technique UVE because you can see, you can do all the debridation and clean and maybe a decompression in patient who have, he said, implant infection. You can, with the continued irrigation, you are clarified, you are clean the space, but at the same time, you can put directly antibiotic or some new implants with antibiotic, and it's really a really good technique now. Are in studies, is not public, some implants with antibiotic, but if these implants, this patient have infection, you do it with the endoscopic technique, all you do a really exhaustive debridement, a really good irrigation with 4 or 5 liters with antibiotic, and you then with direct visualization with the endoscopic, you can put the antibiotic or even pearls with antibiotic and directly to the implants or close to the implants, and it's a really great solution. Yes.
Wow, thank you very much. Dr. Ertan Sevin, it was a very nice presentation. Dr. Brenda, thank you. Dr. Ertan Sevin from İzmir.
Thank you.
And we have one more comment from Donghyun Lee. If you expect instability after decompression, what is your strategy?
South Korea, I
Well,
think, right?
Yes, South Korea.
Okay.
yes, sometimes I can see it in my follow-up patients. If I expect, I follow very carefully because sometimes they don't do it, don't develop it. So I have this expectation, but when I have, I try to do a core rehabilitation for the spine don't have a lot of weight, and if with the next year don't develop this instability, that is don't happen. But if it is, I follow the patients and prepare the patient for the convert to endoscopic fusion. Yes, maybe in the next almost 8% pain until 6-8 months after surgery, after the compression. Yes.
Thank you,
Madonna,
Dr. Donghyun Lee.
maybe
Yes.
we should give the stage to Zorian before Mustafa.
Of course. Yes.
Yeah, Zorian. You can turn on your microphone, Zorian. No, you
He's
can turn
muted.
on your microphone.
Yes.
Now
Do,
I
do
can.
you hear me?
Yes.
Yes.
Yes. Greetings to all. I'm glad to see Brenda again. Our first
Yes,
time,
nice to see you too, doctor.
we meet you in Argentina. I remember.
Yes.
And I'm glad to hear that endoscopic techniques are going popularity. And Brenda's presentation was perfect. Well done. But and I like the UB technique. I like UB technique too. And I start my endoscopic technique with UB too. But sometimes in rare extraforaminal hernia location, the monoportal techniques is interesting in my opinion. And I have question to Brenda. Do you plan master or learn the monoportal technique in the future? What do you think about that?
I agree with you totally. First of all, I really glad to see you again, Dr. Yuri. I meet in Argentina and then see you in Tulum, I guess. And I do monoportal now, specifically for foramen. I definitely see some advantage, especially in some mid-grade disherniation and extraforaminal. Definitely, to me, it's very important now the surgeons learn both techniques because sometimes, yes, for in my case, I do my 85% or 90% with UVE because I love it. It's very, can you do a lot of things with UVE? But uniporal, I guess I know a lot of uniporal surgeons, they can do anything with uniporal because they are master of the uniporal endoscope. So to me, learn the uniporal was really interesting because I saw some advantage too, like you said, in foraminal pathology. It seems look really good option. Do it with uniporal. Yes, definitely.
Thanks.
Yes.
Thank you.
Thank you very
Thank you,
much,
doctor.
Dr. Yuri, Dr. Brenda, for your
Dr.
response.
Zorian, not Yuri. Yuri
Okay.
is not in.
Sorry. Yes.
Zorian.
Sorry. And we have thank you from Dongkyung Lee from South Korea. It was a great presentation. It's a difficult decision. And
Okay.
a question from Dr. Muhammad Sadef. Considering your dominant hand is the right hand, do you always prefer a left-sided approach in UBE, or do you actively use the right-sided approach as well?
I will always do depend of the pathology needs. I don't have the limit of if I have a hand right surgeon, but if I need a right pathology, I change my approach to the right side. It's different the plan of the portals. You need to plan different. Go almost 1 centimeter low than you playing in the left side, but the work is the same. To me, no represent a difficult. Go to the right side. Yes.
Thank you very much. Kamil Hoca, do you have any questions or comments?
Yes, but before that, we have Musa Ibrahim from Nigeria. He is actually monoportal surgeon, but maybe he want to say something. Musa Ibrahim, are you here still?
Yes, yes, yes.
Okay.
Hello. Do you hear me?
Yes, we
Yes.
can hear you.
Yes. Thank you, Doctor, for this good presentation. Yes. Biportal is good, but how about, do you ever evaluate the post-surgical side pains after monoportal and biportal? Any differences? And when it comes to tissue destruction, yes, in monoportal, there is less tissue destruction than biportal. Have you ever experienced after doing biportal, drilling and bone work and whatsoever, then the patient comes back to you with instability? Thank
Yes.
you.
Before that, sorry, Brenda, I want to add something. I wonder Musa Ibrahim's opinion. Zorian, for me, not only in foraminal disc herniations, also in midline, huge disc herniations, transforaminal endoscopy has advantage, I think, because in posterior approach, you have to retract the dura in the midline disc herniations. But in transforaminal technique, you don't have to retract the dura. So not only in foraminal disc herniations, also in midline big, huge disc herniations, transforaminal technique has advantage because it's really difficult to retract dura in this kind of herniations. What do you think, Musa Ibrahim, about this?
Yes, this is correct. Even 2 days ago, I had a very huge disc herniation, and I went interlaminar. And yes, unless you go extreme lateral, you can injure the dura or the nerve root. But transforaminal, yes, I think is the answer. You can just directly to the disc and then remove it, and it has advantage. It's more than your uniportal interlaminar, and is more than UBE. That one, yes, I can say it.
Okay. And sorry,
Because
Brenda.
it's more direct to target. Your aim is direct to target, and you remove it, and you are done.
Okay. Let's go your question to Musa Ibrahim. He asked about the tissue destruction.
Damage after
The
tissue.
tissue
And then
destruction, yes.
depends after the surgery between uniportal and biportal.
Yes, it's something that I saw. It is really interesting, specific in the beginning, because with bipolar, you need to know you can produce a lot of damage, even the open surgery. And we know the posterior elements is very important to stability. You need only the bone wall or the facets, even if you produce a neural of the multifidus, this could be some target to in future instability and pain, of course. And with bipolar, it's easier to provoke this than monopolar. But when you triangulation is in a no insert muscles, and then you go to always close to the bone, you need to do this. But this is something happening in the beginning. After that is almost the same tissue than the uniporal when you have enough experience. But at the beginning, yes, definitely with bipolar you can produce more tissue damage. Yes.
Thank you. How about the
Thank you.
pain? After surgery pain between
About the pain, yes, after
bipolar and
post-op,
monopolar. Yes, post-op
yeah,
pain.
in post-op, right now for me it's the same, but at the beginning I don't expect because I saw my professors and then all cases were success. But when I start by my own, in my first cases, I don't understand what my patients have pain after endoscopic surgery. So I start with saw my own videos, record my own surgeries. It's always so and study and try to learn something what can improve on my own surgeries, and also that I use a lot of radio frequency a lot. So now I use the necessary, do more my own work, sometimes do it with the drill if it's necessary, if have enough space only, the decompressions with Carrison and small drilling. But yes, it's something that I learned. And another thing I saw is the use of fluid inside of the canal. Sometimes it's necessary you be put a drain just for control more or more tolerate the post-op pain. And I talk about this with my professor in Korea, and yes, they say they put always because sometimes in bipolar it's difficult to drain all fluid. So the patients have fluid inside, and they can go out, but it have some pressure inside after post-op. So you put a drain, and yes, the pain post-op after UVE was improved. I don't do that now, only when I do multi-level or fusion, I put the drain, but it's a discernation or single level, I don't put drain anymore. Yes.
Thank you for your honest response. Thank you, Dr. Musso, for your questions. Camiloja?
It was a great lecture indeed. Thank you, Brenda. And it was a great discussion session.
Thank you.
And there were many contributors from many countries. I want to thank especially for my Ukrainian friend, Zorian, Sergi, Musa Ibrahim from Nigeria. And we have from Cameroon, from India, from South Korea, and Azerbaijan, Georgia, like you, Madonna. And I want to thank again to Brenda for this excellent presentation. And I want to thank everyone who joined us today, this evening, this morning for Brenda, because we have 10 hours difference between us. Okay, hope to see you again.
Thank you.
Thank you so much, everybody.
Thank you. Bye-bye.